Hello and welcome to our latest video. In today's presentation, we will be providing an overview of gestational diabetes mellitus, specifically tailored for medical students and healthcare professionals. Gestational diabetes mellitus is a condition that occurs during pregnancy, where the body's ability to manage blood glucose levels becomes impaired. It is a relatively common condition, affecting around 7 to 10% of pregnancies worldwide. However, the prevalence can be higher in certain populations, with South Asians, Africans, Hispanics, and indigenous groups at increased risk. In Sri Lanka, approximately 10 to 15% of pregnant women develop GDM. Who is at risk of GDM? There are several factors that can increase a woman's risk of developing gestational diabetes. These include a previous gestational diabetes. If a woman has had GDM in a previous pregnancy, she is at a significantly higher risk of developing it again. A BMI over 30. Obesity is a major factor in insulin resistance, and a body mass index above 30 before pregnancy increases the likelihood of GDM. A family history of diabetes. A strong family history of type 2 diabetes, particularly in first-degree relatives, raises the risk. A polycystic ovary syndrome. PCOS, which is often associated with insulin resistance, predisposes women to gestational diabetes. Advanced maternal age. Women over the age of 35 are more likely to develop GDM, as pancreatic beta cell function declines with age. A macrosomia in previous pregnancies. Having previously delivered a baby weighing over 4 kilograms increases the risk of developing GDM in future pregnancies. Excess weight gain during pregnancy. Gaining too much weight, especially early on, can contribute to insulin resistance and the development of GDM. Screening for gestational diabetes. It's important to screen all pregnant women for GDM, particularly those who present with risk factors. Organizations such as the World Health Organization (WHO), Sri Lanka College of Obstetricians and Gynecologists (SLCOG), and the Sri Lanka College of Endocrinologists (SLCE) recommend standardized screening processes. At the first antenatal visit, all pregnant women should be screened for GDM. If the screening is negative, it should be repeated between 24 and 28 weeks of gestation, as insulin resistance typically increases during the latter half of pregnancy. If GDM is diagnosed, follow-up monitoring is essential, and women should be screened again 6 weeks after delivery to assess for the development of type 2 diabetes. Diagnostic tests for gestational diabetes. The oral glucose tolerance test is the gold standard for diagnosing GDM. It is typically performed using 75 grams of glucose, with blood glucose levels measured at fasting, 1 hour, and 2 hours after ingestion. Other tests include fasting blood sugar. A fasting glucose level equal to or above 92 milligrams per deciliter may indicate GDM. Postprandial blood sugar. This measures blood glucose levels 2 hours after a meal. A random blood sugar. While not diagnostic, this can be used for initial screening. HbA1c. Though primarily used for managing type 2 diabetes, HbA1c can provide insight into long-term glucose control. A urine dipstick test. While not diagnostic, glucose in the urine may indicate the need for further testing. If a screening test is positive, a diagnostic test such as the OGTT should be conducted to confirm gestational diabetes. Complications of gestational diabetes. GDM can lead to complications for both the mother and the baby. For the mother, complications include an increased risk of preeclampsia and gestational hypertension, or a higher likelihood of requiring cesarean delivery due to fetal macrosomia, a future increased risk of developing type 2 diabetes. For the fetus, complications include a macrosomia, excessive fetal growth, which may lead to delivery complications such as shoulder dystocia, a neonatal hypoglycemia. The newborn may experience low blood sugar after birth, or a higher risk of respiratory distress syndrome and other perinatal complications. Management of gestational diabetes. Managing GDM is crucial for ensuring a healthy pregnancy. The primary treatment approach is medical nutrition therapy, MNT, which involves a carefully planned diet to maintain appropriate gestational weight gain and regulate blood glucose levels. If dietary control is insufficient, oral hypoglycemic agents like metformin may be prescribed, though insulin therapy is often the first-line treatment when blood glucose cannot be controlled through diet and oral agents. Maternal monitoring. Women with GDM are encouraged to monitor their blood glucose levels at home, particularly before and after meals. Post-meal readings, especially 1-hour values, are critical for tracking maternal glucose control. Fetal monitoring. The main concern in GDM is macrosomia. Regular growth scans are recommended every 2 weeks to monitor fetal size and development. Additionally, amniotic fluid volume should be checked to assess for polyhydramnios, a potential complication of poorly controlled GDM. Long-term risks of gestational diabetes. GDM doesn't only affect the pregnancy itself. There are long-term risks as well. For mothers, there is a significantly increased lifetime risk of developing type 2 diabetes and hypertension. For the baby, GDM can lead to childhood obesity and an elevated risk of developing metabolic syndrome or type 2 diabetes later in life. If you have any queries, please feel free to reach out. You can send your questions to the email address